Okay, folks. So, to put this in perspective, so this is a simplified diagram. This isn't in your book. It's the only place you're going to see it. And it's from the literature that I've given you. And you'll see it all over the published literature. But I wanted to give you kind of a sense of the time frame. And what you can appreciate in the very first few hours is where you get vasodilation. And you get transudates and exudates leaving the vasculature. And that's where you get your tissue edema. Right? This is where you get your swelling. Right? Now, one of your classmates just showed me at the break a picture of their 5-year-old son who just fell on his head yesterday. And you can see that it's red. You can see that it's swollen. Right? You can see that you can appreciate it's probably painful because you can just imagine it hurts to touch it. Okay? Or comb his hair. I imagine he won't let you comb his hair if he even let you before. But so that happens right away. And then within the first 24 hours, you get your first responders. You get the neutrophils leaving the vasculature, coming into the tissue. Okay? They're smaller in size. And so it's a little easier for them to get out of the blood vessel. They go more quickly. Within the first 2 days, like 48 hours, you get the monocytes leaving and turning into tissue macrophages. So our first cells that respond into the tissue are neutrophils. They're the first cellular responders in an injury. And they're very, very closely followed by the second responders, which are the tissue macrophages that came from circulating monocytes. And this last third curve of these monocytes and macrophages, if this stays elevated, like forever, that's chronic inflammation. Okay? And we'll see here in a minute, I keep pointing back to this, but just remind me, those macrophages, when they stick around there forever, they actually fuse and form these foreign body giant cells, and we'll get there. So, inflammation. We have some different types, and we have some resolutions that take place. So we've got serous, fibrinous, superlative, and ulcerative. So serous inflammation is watery. It's protein-poor fluid. It's a lot of fluid effusion that leaves, usually like in a serous cavity. A really good example of a serous inflammation would be a blister. Like a blister is full of fluid, right? You pop the blister and a bunch of stuck fluid comes out. That's transient. It's captured in that blister. All of us have had blisters, okay? And you know that it's clear fluid that comes out. If it's not a blood blister, right? It's just a straight old blister. It's just clear liquid. That's one of the best examples of a transudate that I can give you. That's an example of a serous inflammation response. Fibrinous. Fibrinous is occurring with more extensive injury. You get fibrinogen at exit, so that's a protein. You've got a lot of coagulum that takes place, or clotted blood, because of the fibrinogen that leaves. Usually you have to have larger capillary permeability than you did with serous. You see this in the inflammation of body cavities. Okay, so fibrinous. Fibrinous is the upper right. That's the picture of pericarditis over the pericardium on the heart. And so you're seeing evidence of fibrinous inflammation on this flap that's being resected back. Superlative or purulent. Superlative really is referring to exudate that comes from the neutrophils, as well as necrotic cells and the endemic fluid. So if there's an infection present, like a microbe, then it would actually be pyogenic. And you're going to have pus. Okay? It's infected. So that would be superlative. Abscesses are just a local pocket or an accumulation of that pus. And the last one is ulcer. That's usually due to erosion. Okay? There's an erosion in the shedding of necrotic cells. It could be from mechanical erosion or it could be from chemical erosion. So the lower left is a duodenal ulcer with an acute inflammatory exudate right at the base of the ulcer. This is that acute inflammatory exudate right here. This is the duodenum or the small intestine. This should actually connect. This little chasm or gap should connect, and this is the ulcer right here. Down here is this fluid, that ulcerative erosion. And then the last picture, that lower right, that's a purulent or a superlative inflammation of the lung. And what you're actually appreciating is all of the neutrophilic infiltration. So all of these purple dots in here are all neutrophils. You can see the red streaks that are in here. This is the vascular supply that's really widely open. Those are all red blood cells that are found within the vascular supply. And that's what's contributing to all of this exudate that's here. This should all be white, like this little gap right here. And it's all full of fluid and cells, okay, in the lung. All right, so what are the possible outcomes that can take place with inflammation? Right, we can have resolution. So we've got acute inflammation in the upper left, and we've got chronic inflammation in the lower left. And as we move from one stage to another, we can see that there are different possible outcomes that can be realized. So in acute inflammation, we can progress over time to chronic inflammation, where we've got a lot of cellular infiltrate, mononuclear cellular infiltrate, and scarring that takes place, as well as the development of new vessels known as angiogenesis to support this new tissue. A lot of the causes of acute or chronic inflammation, if it moves on to chronic, are like viral infections, chronic infections that take place that don't resolve, or repetitive injury to the tissue, and that would be in the category of autoimmune diseases. They cause repetitive injury to that tissue. And so that's in the category of chronic inflammation. From acute inflammation, you can see some of the injury stimuli that are here, also infections, trauma, toxins, or infarction due to a loss of blood flow. But this can resolve. This can resolve where the vasculature regresses. It goes back to its native architecture. You get the clearance of the injury. It's no longer present, right? So you don't need that blood flow. The clearance of the mediators and the acute inflammatory cells, they go away. They dissipate. And then you restore normal function. That's the key, is the restoration of normal function of that tissue. And that's true resolution in the upper right. Now there's different stages along the way. Chronic inflammation or resolution, there's these intermediate steps where you can have an inflammatory event where you've got an abscess because you have a pyogenic infection or you've got a microbe present. And you can institute some level of healing at these stages that may be not returning to normal function, but it's not chronically inflamed, and this would be scarring. And all of us can see an example of this probably on your own body. Okay? You all fallen off a skateboard, wrecked on your bike when you were younger, and have a scar in that skin. And it's not chronically inflamed, but it's not normal function. Why is it not normal? Well, if it's a cut on your head, maybe the hair didn't grow back, so you still have a scar. And there's no hair that grew back into that tissue. So if there's no hair cells, it didn't go back to normal function, right? If it's on your arm or your leg or somewhere, and you touch it, it's maybe stiffer than the tissue around it. It's fibrotic tissue. It doesn't have the same mechanical function. Okay, so a scar in a tissue is a type of healing response, but it's fibrotic healing. Okay, okay? And so you haven't restored normal function of the tissue. You've kind of spackled the wall where you hung a picture, but you can still kind of tell where, you know, the nail hole was. Does that make sense? Okay? And like some of our spackling capabilities, you know, all of us don't have wound healing that occurs at the same level or completeness. Some of us heal better, and some of us heal not so well. Okay? So these are just kind of this is a map of all the different possible outcomes. And we're going to talk about this a little bit more next week when we talk about wound healing. We'll talk about the different stages, and I'll show you some examples as we get into next week. Right now, I want to talk mechanistically. I want to talk mechanistically and show some of our scarier slides for the day. Okay? So we're going to walk through these relatively methodically, but these chemical mediators, they come from places. They don't just spontaneously show up. So I'm going to talk about where do they come from. Well, it comes from the cells at the site of injury. And the cells that are at the site of injury could be the injured cells themselves, or it could be the cells that are recruited to the area, like the leukocytes. And so those are the sources of these chemicals. Like, for example, if it's a mast cell and it gets traumatically injured, it's going to release histamine. Right? If it's a leukocyte and it's recruited to the area, it can either release chemical mediators that it already has stored inside of itself. It just fuses with the membrane, the vesicle fuses with the membrane, and it dumps its content. Or it can manufacture new molecules, new chemical mediators from scratch. And that's what we refer to as de novo chemicals, or de novo synthesis. So let's look at these. At the level of, and then the second category, so cells at the site of injury or the plasma itself, right? Because like the blister example, you either have cells that are injured, cells that are recruited, or you've got fluid that's extravasated out, right? It's left, it's a transudate, it's there, and it could be containing, and it does contain plasma, because that's mostly what it is, and it's got chemicals within it, okay? So, at the level of the injured cells, the leukocytes, and the plasma, we've got cell-derived components, and then we've got plasma protein-derived. So we look at the cell-derived, the cells make them, right? The cellular machinery is active, if you remember basic bio, right? So the DNA signal is translated or transcribed into messenger RNA, and that's translated into protein. That protein is packaged in these vesicles, and then they're fused with the membrane and dumped out. So these chemical mediators are proteins that are made by the cell using the cellular machinery. Okay? So you wonder, why did I have to memorize transcription and translation? Right? It's because it's such an important process of the cell to make chemical mediators for the cell to live and exist and actually help you. So now we've got these preformed granules that are already there, things like histamine and serotonin. You can see the sources that they come from. There's our mast cells. Then we have newly synthesized ones, like things like prostaglandins, leukotrienes, PAF, platelet activating factor. This comes from platelets. We've talked about reactive oxygen species. We've talked about nitric oxide. And other cytokines like the interleukin family and TNF-alpha, tumor necrosis factor alpha that we talked about. That would be an example of the cytokines. And we'll talk a little bit later about the neuropeptides. So the prostaglandins and the leukotrienes are coming up, so hang tight. But many of the others we've actually covered, or we will cover. And then, of course, in the plasma, the liver makes the plasma proteins. The liver manufactures the proteins that are released into the plasma. And you've got two major families. You've got the factor 12 family, which is made up of the kinin system and the coagulation system. And then you've got the complement family, which is made up of the family of C3 and C5. So if we start out by talking about our cell-derived components, and we look at our two different pathways that we can follow. We can go through this family that's going to derive these prostaglandins and these prostacyclins, and we have the family that can derive these leukotrienes. And these are our major trees of chemical mediators that we have not yet talked about. Where do they come from? These are in the family of what are known as eicosanoids. So eicosanoids are signaling molecules, and they're manufactured by oxidizing carbon fatty acids, carbon chain fatty acids. There's 4 major families of eicosanoids. The 4 major families are prostaglandins, prostacyclins, thromboxanes, and leukotrienes. And they're all on this particular slide. So what do you mean by coming from fat? Okay, so for example, the cell membrane phospholipid at the top, this is where we start, and I'm going to highlight so you can highlight where we're going to end. We're going to end on a family of prostacyclin, thromboxane, prostaglandins, and leukotrienes. We're starting with phospholipids, and we're ending with a family of 4: leukotriene, thromboxane, prostaglandin, and prostacyclin. Okay? So, how do we get there? Well, the phospholipid bilayer is recycled using a phospholipase. The lipase is an enzyme that breaks down the phospholipid into arachidonic acid. AA, arachidonic acid, can then be utilized to form 2 intermediates. To the left, you see cyclooxygenase, and to the right, you see lipoxygenase. The cyclooxygenase pathway gives rise to 3 of the 4 family of leukotrienes: prostaglandins, prostacyclins, and thromboxanes. The lipoxygenase gives rise to the leukotriene family of eicosanoids. And then in the boxes, you can see what they do. And here's what I want you to be able to remember for the exam, is I'd like you to know that the prostaglandin family stimulates vasodilation. Okay? So you manufacture this eicosanoid, it's packaged in the cell gets injured, it releases its content, and it contains prostaglandin that stimulates vasodilation, and that triggers repair. Make sense? Cell manufactures prostacyclin. This also gets damaged and releases and causes vasodilation. Now, this one is weird. These 2 are vasodilation, and this one's vasoconstriction. Why would you do both? Any idea? Yeah.
Would you need it for like the phase, like
Post healing?
No, post like what was the words? This side
Resolution?
for the blue side, or your veins.
The venous side.
Yes.
Yeah. So the idea here is you want to vasodilate to get things started, but you want to have a vasoconstrictor so when you're done with the response, you don't leave it vasodilated. Okay? So this is actually just a little bit more delayed in the production of the thromboxanes. But you're already preparing for the back end of resolution on the venous side of the circulation where you actually want to kind of clean things. Okay? Now let's look at our family of leukotrienes. You take phospholipid bilayer, intermediate of arachidonic acid, you manufacture leukotrienes. Well, this is going to increase vascular permeability. Okay? These vasodilate and you increase permeability. That's getting those cells out into the tissue where the healing needs to take place. You guys don't need to worry about lipoxin. Don't worry about it, okay? We won't cover it. Questions over the eicosanoids. These are signaling molecules that are manufactured by the cell. They perform critical functions in allowing for inflammation to be facilitated.
Do you know the enzymes such as lipoxygenase?
Now, what I want you to know is phospholipids to arachidonic acid, 2 different pathways. I'd like you to know the cyclooxygenase pathway gives rise to the 3, and the lipoxygenase gives rise to the 1. Okay? And then the other thing I want you to understand is, do you see, if I gave you an aspirin a day to lower inflammation, do you see how it does that? Do you see that aspirin blocks cyclooxygenase? that's why aspirin is a nice anti-inflammatory agent. But it keeps open the leukotriene pathway. So aspirin, as an over-the-counter, blocks inflammation, but it doesn't eliminate it broadly. The other thing that does that are COX-1 and COX-2 inhibitors. But look at what glucocorticosteroids do, or just steroids in general. It blocks way up here, and you eliminate both families of arachidonic acid. And so this is prescription strength up top, and this is over-the-counter down here. Does that make sense? So that's the difference. So if you have a patient, one second, if you have a patient that's on aspirin every day, and then they're going to go on to a steroid anti-inflammatory, a lot of times they'll discontinue the use of the aspirin while they're taking the steroid, because the steroid is more broad. Make sense? So this is a little of the pharmacology of why we use certain kinds of medications. Okay, question here and up front.
Where would antihistamines work? Would they work in that area, or is that completely something else?
The histamine, the antihistamines, they block the release of histamine, which is a different pathway than this one. So the histamine family is here, okay? And we're talking about the prostaglandins and the leukotrienes. So the antihistamines are going to act on histamine themselves, and it's going to lower the vasodilation and the swelling that's associated with histamine. But the leukotriene and the prostaglandin activity is still in full play. Question?
Yeah, but back to the slide where you show the aspirin, or it blocks vasodilation, but it doesn't stop chemotaxis. Does that mean if we were to take aspirin, it will sort of slow down the body's process to eliminate just pretty much just reduces someone's suffering of their condition?
Well, so aspirin is very effective, but aspirin is only going to block one pathway, right? So yeah, it slows it down, but it won't be quite as aggressive as like a steroid block. But I mean, it works really well. Okay. Some plasma mediators. Some plasma mediators that we need to look at. And I have a summary slide after we get through these mechanistic pathways, okay? A summary slide I think is very helpful. But this is in the family of complement. And so what complement, there's three different pathways. There's the alternative pathway, which is at the top. There's the classical pathway, and then there's the lectin pathway. I just want you to know that there's three pathways, that they converge, and complements are a system of a biochemical cascade that helps or complements the ability of antibodies to clear pathogens from the organism. So complement in of itself doesn't do anything all by itself. It helps to facilitate the activity of antibodies to fight infection. And so you can see that all three of these converge into this pathway, this common pathway, C3b. Okay? C3b can go on and it can actually stimulate C3a. C3a and C5a can trigger an inflammatory event and allow for the destruction of microbes by leukocytes, like what we talked about. C3b can go on here and bind to a phagocytic receptor and cause the ingestion of the microbe using phagocytosis, which we've also talked about. C3b can actually move on. It can create what's called this membrane attack complex, which is shown here, which basically puts a hole in the membrane of the microbe, and it causes fluid to rush in, and it lyses the microbe. And we've not talked about that one yet. Okay? So this is a tool of the body. It's a complementary tool. It's pretty cool, but it stimulates, bless you, the main pathways that we've already talked about to be active or complementary. And it also has kind of this cool little unique MAC complex formation that takes place. Now the last mechanistic pathway, and then I'll get to some questions after just this slide and one more, and then we'll wrap up this little section. Kinin and coagulation. Okay, so this is back to 202. You guys remember 202 when you looked at the blood coagulation pathways? We've got factor, Hagman factor, right at the top. Factor 12, Hagman factor. And it goes 12 to 12a, and it goes 12 to 11 to 11a, 10 to 10a, so on and so forth down this cascade of events, right? And you end up with fibrinogen going to fibrin. And this is the clotting cascade. And then over here, we actually have what's called the kinin cascade. And the kinin cascade also starts with factor 12, but factor 12 going to 12a takes pre-kallikrein to kallikrein. And this stimulates the bradykinin system to trigger this fibrinolytic cascade that triggers the activation of the complement cascade through plasmin. Okay? So plasmin stimulates C3 to C3a, which was the previous slide that we just looked at. So the big take-home messages on this slide is factor 12 can either trigger the complement cascade, which stimulates phagocytosis, cellular lysis, the things that we just talked about, and it also triggers blood clotting. Now, explain to me why controlled coagulation during inflammation would be a good thing. How would that be even relevant to inflammation, blood coagulation?
Does it have anything to do with, like, not going to coagulative necrosis?
No, not really. That's a good guess. Okay. Think about the blood flow and fast blood flow versus slower blood flow at the level of damage.
Is there a faster blood flow, maybe physical and chemical, where blood length will slow down blood loss, while at the same time it could localize a lot of the proteins it needs for the cellular?
You got it. So two things. If it's a major traumatic event, you don't want to lose blood, right? So you're going to coagulate the blood, not bleed out. But even if it's not to the point of a trauma where you're losing large volumes of blood, if you control the blood flow and slow it down in the form of controlled coagulation, you allow for those cellular elements to come in contact with the endothelium to an easier extent. And so extravasation is actually better, right? You can get the monocytes out easier than if the blood is flowing quickly. Make sense? So that's why the body does, and all of these mechanisms are happening simultaneously. They're all happening at the same time. So here's a summary slide of what we just talked about from a mechanism standpoint. We have vasoactive amines. We've got histamine. That's where your antihistamine works. Okay, the question about antihistamines, that's at the very top right there. Histamine released by mast cells, basophils, and platelets. It stimulates an increase in vascular permeability, and it allows white blood cells to exit to the tissue. If you take an antihistamine, like an over-the-counter antihistamine, like Benadryl, that's an antihistamine. It blocks this right here. Serotonin. This comes from platelets. It stimulates chemostasis and blood clotting. This is important for the thing that we just talked about, right? With the coagulation cascade, which is all the way at the bottom. Serotonin does the same thing. We talked about the eicosanoids, the family of 4 carbon chain molecules that are derived from phospholipids, and they form an intermediate known as arachidonic acid. They have vasoactive effects, right? They stimulate vasodilation as well as some vasoconstriction. They cause chemotaxis, and in extreme cases, they cause bronchiospasm. And then the complement system, we talked about the increased vascular permeability cause vasodilation. They activate the leukocytes, cause chemotaxis, and then they stimulate phagocytosis here. And then last but not least, the kinin and the coagulation pathways that are involved in chemostasis, as well as the formation, kinin, the formation of the complement system. Okay? Questions? Did you have a question that I didn't answer earlier?
Yeah, but it was a joke.
It's a joke. Okay. Yes?
Why does chronic inflammation lead to loss of function instead of medical?
Oh, that's a really good question. So the question is, why does chronic inflammation lead to a loss of function but not necessarily to metaplasia? Well, so in the beginning phases of chronic inflammation, it will be scarring and fibrosis. If it continues long-term, when we get into the cancer lecture, you'll see, long-term chronic inflammation can in fact lead to metaplasia. And that's actually what we see with Barrett, like the first clinical example that we talked about. We see metaplasia because long-term, that HCl that keeps coming up into the esophagus is causing an inflammatory event to take place. And that over 10 years is going to slowly lead to cellular metaplasia. Okay? All right, the last segment for today is relatively short. Okay, I promise. You're like, there's like 40 more slides or something like that, though. Yeah, you'll see. Those are bonus slides for those like gunners in the class. Okay? Some of you are like, oh shoot, that's not me, Kelsey. No, I mean, some of you are just interested. And I always get asked questions about more. So I put some more stuff there. But I'll tell you where we're going to stop and where we're, it's just for your reading enjoyment. We won't test you on it. But this is testable, okay? I repeat, for those of you at home, this is testable. Chronic inflammation. So we've alluded to some things about chronic inflammation, like time-reported body giant cells. Here is the comparison straight up, okay? So we look at acute on the left, and we look chronic on the right. Now the slides are, they're totally different slides. They came, where did they come from? This came out of a manuscript from like the 1980s, you can tell, right? This one came out of a publication like in the 1990s. Oh no, this was a graduate student's dissertation, never mind. This is like a 1980s publication, and this one was like 2000, maybe 10 or something like that, okay? So acute, you've got inflammation, which is that first big peak. What cells are the first responders? Neutrophils, very good. Which ones come second? Tissue macrophages. They come from circulating monocytes. Very good. Seems like people were listening, right? That's great. So this is that first phase of inflammation, and that happens in the first few hours. And then you've got this peak of cell proliferation and matrix deposition, and then you've got the remodeling. And in a year period of time, so a wound takes a full year to heal. I don't know if you've heard that before. But if you get a cut, it's remodeling for almost 360 days. About 300 to 360 days, it remodels. The scar will fade over time, but after a year, it's probably what it's going to be for the rest of your life. Okay? Now, this is a year. Okay? The difference here is, here's the kind of relative time here, minutes, hours, days, weeks, right? This is like a lazy author. All right, what's the time? Yes, it's time, right? and so here you've got chronic, and you've got all of these things that stay elevated. Like neutrophils come up and go, but look at macrophages. They come up and they stay elevated. New vasculature, new blood vessels, they come up and elevate. Foreign body giant cells, that's that FBGC. Foreign body jump, come up and stay elevated. Fibroblasts, up and elevated. Fibrosis, scarring, up and elevated. Like the only thing that really comes up and goes and fades in chronic are the neutrophils. So let's take a look at some of the examples here, right? We see lung tissue on the right. Upper right, chronic inflammation. Lower right, acute inflammation. So the big difference is, like in the upper right picture, that yellow asterisk, that's a collection of chronic inflammatory cells that have been there for a long period of time. The arrows, right? The arrows are fibrosis. That's connective tissue that's been replaced. And you've got fibrosis of that lung tissue. In contrast, on the lower right, we see that there's neutrophils filling the alveolar spaces. So all of this tissue here, like, do you see the red outline, kind of this red outline of this? Everything in between those are all neutrophils. These are all macrophages. The neutrophils are temporary. They're going to come and go. So this is acute on the bottom with neutrophil infusion, and this is chronic up top with scarring, with chronic macrophage infiltration, and fibrosis. And then the arrowheads are destruction of the parenchymal tissue. This is almost a cellular metaplasia that's taking place. And the normal alveoli are being replaced by cuboidal epithelium, right? And that's the arrowheads themselves. So these cuboidal epithelium right here, those are not normal. That's cellular metaplasia to the question that was asked just a few moments ago. So in characteristic chronic inflammation, we get mononuclear infiltration, tissue damage. We see evidence of cellular metaplasia. We see the healing response, limited repair, marked angiogenesis, and lots of scarring. So these inflammatory cells in the chronic phase, right? The neutrophils are the first responders. They come up and they dissipate. The monocytes are activated tissue macrophages. They stick around for a long period of time and they fuse. And as they fuse, I'm going to show you on the next slide, they become these foreign body giant cells. Here what we're talking about is we're talking about the different interactions that take place with a macrophage. So here's a macrophage. Here it is in an activated state. You can see how it kind of has like, its feathers are ruffled, or it's got, kind of spiky fur, right? In its activated state. And it's cranking out all of these chemical signals. It's making tumor necrosis factor, interleukins. It's making interleukin 12 that has activity on T lymphocytes. These T lymphocytes move on and have other inflammatory activities in the tissues. And the activated macrophage also stimulates other macrophages to be recruited to the area. We'll talk more about T lymphocytes and even B lymphocytes in our specific or our adaptive immunity lecture. But what I want to do to finish this up for today is just introduce this idea of foreign body giant cells and how it comes to play in the medical community. Okay? So someone at the break asked about tuberculosis. Okay? Tuberculosis is something that is found in the lungs, and usually the tissue will see it as foreign, and so it will wall it off. Anytime you have a medical implant, okay, even a splinter, will be considered a foreign object, and the body will wall it off. And as the body walls it off, it's a healing response, and it triggers a couple of things. It triggers, and you can see in this tissue right here, this is the walled off giant like epithelioid cell, right? And out here is all of the inflammatory tissue, and in here is kind of the collagen mass that's being walled off. These blue arrowheads are pointing to, or these blue arrows are pointing to these foreign body giant cells. Do you see how many nuclei are present and how big they are? So literally, and this was James Anderson that coined this term, foreign body giant cell. So the multinucleated foreign body giant cell are all these tissue macrophages that are trying hard to engulf the foreign object, but they can't. So what they do is they fuse to join forces and make a multinucleated, many cells that fuse, and they together try to attack and digest away the foreign object. So the cobalt chromium hip that I showed you just before the break, you would see foreign body giant cells there. Okay? A splinter that's been in the body for years, you would see foreign body giant cells there. Okay? Tuberculosis in the lung, you would see a fibrotic lesion, and you would see foreign body giant cells there. Any foreign object that's been there for a long period of time, usually a long period of time, is anything that's greater than about 28 days. It only takes 28 days for foreign body giant cells to be there. Between 14 and 28 days, you'll start seeing evidence of foreign body giant cells present, but by 28 days, they'll be there. Okay? Show another histology example. Okay, got it. Check. That was my clue to myself. So, this is, have you guys ever been to the gym and ever seen these commercials? They're really just disturbing, but they're like a hernia repair. Have you had a hernia patch? Call now, right? And it's some super honest looking person with a 1-800 number, right? Kind of dressed like me. That's a lawyer that wants to have you join a class action lawsuit. So these hernia patches, they're manufactured by many different companies. What was the Bleeding Edge? Did you guys see the Netflix movie Bleeding Edge? Did we see that? You guys haven't watched that? Are you serious? Nobody's watched that? Has anybody heard of it? Okay, so you should watch it, and then we should talk because it's obviously paid for by an interest group. You guys know that, right? Like these documentaries get published by certain interest groups. Like someone has to fund it. I mean, don't be naive, right? And so somebody pays the bill, so they're trying to get an agenda across. Okay, but what was captured in that video, okay, is real. There were problems with these hernia patches. They're made of polypropylene. A lot of them are made of polypropylene. They're highly inflammatory. And if you had like an umbilical hernia, or if you had pelvic floor reconstruction, a lot of women would have this post-pregnancy for urinary incontinence. And they would be implanted into the abdomen, and they're highly inflammatory. And over time, some of the patches actually would work themselves out of the body. And the woman would have like polypropylene mesh poking out of their skin because the body's trying to expel it out. Okay? It's really bad stuff. Okay? So these open white spaces are where the polypropylene is, and you can see all the inflammatory cells around it, and then these are foreign body giant cells. All of these red arrows are pointing. Here's a really obvious one right here, foreign body giant cell. This was implanted into a tissue for 14 days. Okay? And then in our lab, we created a coating around this polypropylene. This is like 15 years ago. We were trying to solve this problem. And we put a coating around it, and you can see we significantly see less purple dots, much fewer purple dots than over here, and no foreign body, well, maybe one right here where the arrow is, one foreign body giant cell. But any implant in the body greater than 14 days, like 14 to 28 days, is going to stimulate some amount of foreign body giant cell unless you have some way to mask it from the tissue. And that's evidence of chronic inflammation versus acute. Okay? So fibrosis, foreign body giant cell presence, and elevated inflammation with scarring, those are all attributes of chronic inflammation. The last portion of the deck is more information about biocompatibility and biomedical implants. Not going to be on the test. Just that last slide is where we'll stop. Okay, does that make sense? Okay. You guys have a great week. Don't forget the post quiz on Friday.